So what about these lubrication injections preserving cartilage? Can they actually preserve cartilage? We haven't talked about that for anything yet. And here we are talking about these injections maybe preserving cartilage. Well, I stated that it increases the lubrication in the joint. It seems to be sustained. So it probably helps protect the cartilage in that way. We think that the injections help at the cellular level. And there's numerous studies that are showing that if you inject the lubricant into, for instance, dog knees that have had their meniscus taken out, and they do better. So if the dogs that had the injection after a meniscus versus dogs that didn't have the injection had less cartilage wear. So some things in the future as far as injections. You've maybe heard of a medicine called remicade. That's something that folks use for rheumatoid arthritis, and it works amazingly. This is kind of beyond the scope of this talk, but tumor necrosis factor is something that's really important, that when it's present in a joint, it just deteriorates the cartilage. It breaks down the cartilage. So you take a pill in rheumatoid arthritis, you take this remicade, and it knocks it down in your whole body. Well, now they're coming up with a local remicade, which is an injection. Again, think of it as a smart bomb, if you will, if you went through Persian Gulf War I, I guess it was, smart bombs. So this is the stuff we want, where we want it, and not affecting your liver and kidney and everything else, okay? There's a bunch of other things out there, but I'll introduce you to these concepts. An antioxidant and acetylcysteine. Again, another substance that they're working on in the lab that seems to protect cartilage. How many of you have heard of PRP, or platelet-rich plasma? Okay, so this is new. Tiger Woods had the injections. The guy that did them up in Canada is getting in trouble. You know, so there's all this suspicion and concern around PRP. Well, PRP is perfectly fine. There's nothing illegal about it. All it is your blood. We draw it from your vein. We spin it down, and we give a concentrated amount of the platelets, which have growth factors and all kinds of good things that help induce healing. So we can do PRP injections, which is your own tissue injected back into yourself at a very concentrated level to all kinds of situations. So people are getting them done in their hamstring strains, their tennis elbow, and some folks are doing injections into the joint. And there's thoughts that maybe if you inject this stuff right in the joint, it'll protect the cartilage. I'm kind of plus minus on that right now. I've had some patients come in and request it. It's not covered by insurance. It's considered experimental right now, so it's a cash thing. And I'm kind of so-so on it. The evidence is really not strong for PRP in my mind. I don't think it causes a problem, but I don't know for sure if it helps. And you know, every injection we do, there's a risk of infection, so you want to know that it's going to help. But we're on the front end of PRP, and I wanted you to know about that term. And then stem cells. So stem cells, this is really where everything's going right now, is stem cells. So the thought is, stem cells, if I get some stem cells from your bone marrow, okay, I can take those cells, I can send them to the lab, and through a series of chemical reactions, I can get that cell to become a different kind of cell, a cartilage cell, for instance, and I can put it back into your knee joint where it grows normal cartilage, right? That would be really cool. So that's where a lot of this is going. So we've talked about all the non-operative things. Now let me talk about some operative things that can help protect your knee or your joint. Well, one of the things we talked about is if a joint gets tight, if a joint gets extremely tight, then the shear force on the surface of that joint is going to be very high when it tries to move. So that Teflon coating is going to see a lot more surface tension. So we do lysis of adhesions, anterior interval releases, scar removals to increase joint pliability. Because if a joint has more pliability, even if it's got that bad looking x-ray, if it's got good mobility and good range of motion, it'll wear the cartilage less, it'll hurt less, okay? So we remove scar tissue. This is Dr. Stedman's pioneered this thought, and this is called the Stedman package, where you release adhesions all over the joint. Patients that have arthritis get joint lining inflammation, their normal joint becomes tight, very tight. So we go in and we use a laser probe, a heat probe, and we release these adhesions. And sometimes that can take a while to do arthroscopically. It can take me sometimes as long to do this as it takes Dr. Bernicle to do a total knee replacement, to just release these adhesions in the knee. And we give the joint back volume so that the tissues can roll around a little bit so that the cartilage isn't wearing itself out just because it's so tight. So we release adhesions, decrease surface tension on cartilage, increase joint mobility. That's what we're doing when we do these procedures to release adhesions. That protects cartilage, right? That's a surgery. Another surgery, arthroscopically done, is joint stabilization. If you have a bad ligament tear of any sort, your knee's going to be unstable, so it's going to increase the shear forces on your cartilage. It's going to wear out your joint. So we want to fix the instability. This is an ACL tear looking from the side. This is the kneecap, tibia bone, femur, ACL tear. This is what it looks like inside the joint with a scope. That's a metal probe on the tear right there. It's flipped over. And then we reconstructed. This is what it looks like. That's an ACL reconstruction. One example of a ligament. So what about that guy or the girl that has alignment problem, right? So they're standing on this all day long. 80% of their weight they're bearing on an area that has no cushion, right? So they're horribly bow-legged. Well, what if you had a car that was out of alignment and you had tires that were wearing the wrong way? What would you do? You would go get your car realigned, right? And you wouldn't put new tires on your car until you got it realigned, right? And you wouldn't rotate your tires until you got it realigned. So that's a basic principle that I talk to all my patients about. I see patients every week that come in that have had a procedure done elsewhere that was meant to restore, regrow, repair, whatever, cartilage here. But they didn't get their alignment corrected. So what do you think happened to them? They wore it out because they're still wearing all their weight through that bubble gum or whatever, right? The stuff that's not quite as good. So you have to add corrective, you have to correct the alignment. So that instead of bearing weight here, you're bearing weight over here somewhere where you have better cushion. So when we go in, if somebody has a meniscus tear, we talked about the blood supply, if it's on the edge, we just try to trim a little bit, a partial meniscectomy. Sometimes it's a small partial meniscectomy, sometimes it's a big one, and sometimes we put stitches in it to preserve it. But we're big on preservation of the meniscus if we can help it. If we can't preserve it, and if it's a younger patient, younger, maybe less than 50, I would say younger, then we can put a new piece in. This is a piece of donor tissue, somebody that donated their body to science that's the right size for the right patient. That's called a meniscal allograft. So we have some cool arthroscopic techniques we used. We get these little bone plugs, drill little holes. We basically put a new piece of meniscus in there, all right? Now, if that person's out of alignment, what do we got to do on top of that? A high tibia osteotomy. All right, so these are big procedures we're talking about, but this is joint restoration. Everybody's wondering, well, why can't you just sew something in there? You know, isn't DuPont working on something you could sew in there? I mean, you would think, right? Some silicone or something like that. This is collagen meniscal implant. Dr. Steadman was involved with this. This is bovine collagen that's been bioengineered, and it's in the shape of a meniscus. And you literally take it from the wrapper, and you put it in there, and you sew it in. And it tends to turn into meniscus. To be honest with you, we don't really care what this is made out of, as long as it protects this, and as long as it doesn't hurt. It could be made out of shoelaces for all I care. As long as it protects the cartilage and the patient feels better for the next 20 years. So we're trying to find something this is called biologics. We're trying to find something to put in there that can become normal meniscus. That's what we're looking for. This donor tissue works pretty well for about 10 to 15 years, and then it tends to break down because blood supply has to come in, and remember, blood supply is hard to come into the meniscus, and it tears a little easier than your native meniscus. So we're searching and searching and searching for great answers. Right now, the best answer, because this isn't on the market, it was on, and then they just pulled it for some other reasons. Right now, the best way to fix the meniscus if a person doesn't have a meniscus, so a 20-year-old young lady who is knock-kneed and it's already torn her meniscus so bad it couldn't be repaired, she deserves a new meniscus because otherwise she's going to be destined for really bad arthritis, okay? Maybe an osteotomy too. So we're trying to prevent that knee from going right down the primrose path, which we know is going to be horrible arthritis and a knee replacement at a young age. So we're trying to cut that off at the pass. So we just spoke about all the things we can do to protect cartilage. We talked about the non-operative things, the pills, the injections, and now we talked about some of the surgical procedures we do, which are all around cartilage to protect cartilage. Now let's talk about actually fixing the cartilage. Let's learn a little bit about fixing the potholes in the cartilage. So here's some examples of what we do. This is, we still do a lot of this, called microfracture. There's another procedure called autologous chondrocyte implantation. That's the one where you do one procedure week 1, you send the cells to the lab in Boston, then you come back 6 weeks later and you inject the cells by an open, it's called ACI. Have you guys ever heard of that? These are first-line procedures. Microfracture beats this every time, not only in cost because it's one procedure, but also because what the end result is about the same. Here's what microfracture looks like. We stimulate the bone. This is literally a natural, organic process we're doing. Bone does not have the capacity to just regrow cartilage on its own. We have to stimulate it to go in that direction. So this is the edge of the cartilage lesion. This is the pothole. We've poked holes into the bone here. We've prepared the cartilage in such a way that it'll accept this. That's blood that's kind of seeping out. It percolates out. It actually fills this pothole, and it becomes like a jello mold, if you will, for about 6, 8, 10 weeks. We have to protect the knee. We have to keep the patient from bearing full weight on it, so they're partial weight bearing this whole time. We use a motion machine, which is not usually covered by insurance, which really bothers me. And then it turns into this. So a year later, you're looking at cartilage. It's fibrocartilage, and it's this stuff here. It's pretty good, and it works, takes away their pain, but it does have some issues, and I'll talk about those in a second. So keep in mind that our future strategies are really built on microfracture. So this is the baseline. We're trying to build off of microfracture here. So the future of microfracture, all these marrow stimulation techniques, we're going to do microfracture. Now we're going to add the viscosupplementation, or we're going to add the stem cells, or we're going to add this, we're going to add that. We're looking for that magic mixture to get that cartilage better, right? So that's why I do microfracture, and 6 weeks out from surgery, I like to do viscosupplementation, because I think that's going to help the cartilage. We just talked about how that high hyaluronic acid maybe helps the cartilage. So I throw it in there, but then insurance companies won't cover it because I'm in the global period. Sometimes they do. So we're doing a study on that too. So high hyaluronic acid injections after microfracture, high hyaluronic acid plus stem cells. These are all really cool things we're working on here. And then there's bone morphogenic proteins. You may have heard about those. There's scaffolds. There's all kinds of things. So we poke the holes, we let the stem cells come out, and then we put stuff in there to make the jello mold better cartilage. That's what we're working on.